Perfecto. Iniciemos con la primera presentación. El doctor Tiago Turri viene del Hospital de Bairú, que es Centro de Liderazgo del Labio y Paladar Hendido en Brasil, y nos hablará de las diferencias entre la cirugía ortognática, su preparación en pacientes fisurados. Adelante.
Hello, everybody. A virtual hug from Brazil to everyone. We know that patients with cleft lip and palate present many particularities in relation to patients without cleft. In this class, we are going to talk about it, mainly addressing orthodontic aspects. The first major difference relates to the frequency at which orthognatic surgery is needed, which is 20 to 66% in cleft patients and only 2 to 4% in general population. In this very useful chart from a publication by Dr. Sand in 1991, we can see the sagittal growth deficiency of the maxilla in UCLP and BCLP patients. Compared to patients without cleft, the maxilla of patients with cleft shows a progressive deficiency of sagittal increment over the years, expressed by the SNA angle. In this brilliant article, published by Chinese researchers in 2016, a comparison between the cephalometric characteristics of class 3 UCLP and the patients without cleft was carried out. See that they are patients in the mixed dentition without previous orthodontic treatment and with skeletal class 3 with the A and B angle less than 1 degree and the anterior crossbite. This allowed us to observe the influence of the presence of the cleft, since both groups present the same malocclusion. The radiograph of the left side represents the group of patients with cleft, and the right side of patients without cleft. Regarding hard tissue, UCLP patients show a shorter maxillary length, a greater gonial angle, significantly lower SNB and SNA, and significantly higher mandibular plane angle and the growth direction vector. See the relevant results in relation to soft tissue. UCLP patients showed more concave soft tissue profile, reduced facial convexity angle, acute nasolabial angle, and more protruded lower lip. Another very interesting particularity presented by Dr. Baik from South Korea in 2009 is that while in most surgical class 3 patients without cleft there is a mandibular prognatism, in most surgical class 3 patients with cleft is the maxilla that is deficiency. The article also shows that the maxillary incisors are protruded in patients without cleft and are retracted due to scarring from primary plastic surgery in patients with cleft. This is a very important difference since the usual pre-surgical orthodontic mechanics in class 3 patients without cleft is to retract the upper incisors and protrude the lower incisors. Whereas in class 3 cleft patients, protrusion of the upper incisors frequency is indicated. As we have already demonstrated in some congresses, the main feature in the surgical orthodontic preparation of cleft patients, especially at UCLP, is the presence of an asymmetry in the upper arch between the cleft and non-cleft sides. To obtain a good occlusal relationship and a good smile aesthetics, it is essential to correct this asymmetry in the surgical orthodontic preparation, as illustrated in these 3 cases. The goal is always to finish the orthodontic surgical preparation with the 6th maxillary anterior teeth divided by the center of the maxilla and symmetrical to each other. It sounds obvious, but It's difficult to obtain symmetry in UCLP patients, as extractions of the anterior teeth are often required. Cleft patients usually also have a transverse maxillary deficiency that becomes a risk factor for the stability of maxillary advancement. These patients should undergo an improvement of their transverse maxillary quality before orthognatic surgery. When the patient is an adult, there is an indication for surgical assisted maxillary expansion. A few years ago, I published an article about it. That which you can access using this QR code. In this article, we demonstrated the step-by-step preparation of the maxillary alignment with a fixed appliance before expander installation, and right after conventional expansion to change the expansion screw for a butterfly opening screw. Take advantage at the same surgery to improve the transverse aspect of the maxilla in the posterior region and anterior region. See the sequence in these occlusal photos. In these frontal photos, where the emphasis is given to the great increase in the intercanine distance, allowing space for two central incisors. Note that this excessively atresia left maxilla is not common in patients without cleft, and its management with surgery alone would be quite difficult, with risks of recurrence or even complications. On the right side, after the transverse correction of the basal bone and the dental velar region, the prognosis of orthognatic surgery will be much better. We know that in the orthodontic preparation of the surgical class 3 patients without cleft, we must protrude the lower incisors to allow for decompensation. Another very interesting particularity is in relation to the lower arch of cleft patients. Sometimes we must think very carefully before protruding the lower incisors of these patients. In these UCLP patients, for example, there is a deep curve of SP, moderate crowding, and a good possibility of working orthodontically without extractions, just with an improvement in the arch shape, maybe a little stripping, and a little protrusion. However, when we look at the upper arch, it is atresic, missing some teeth, and the perimeter is already reduced. The recommendation here is to avoid complete decompensation of the lower arch, because we must consider these particular characteristics of the maxilla. In this case, therefore, we work with the extraction of the lower second premolars. Note that this approach allows a correction of the curve of SP and the crowding without protruding the incisors and without increasing the lower arch perimeter. Here, the patient is ready for orthognatic surgery with the 6 anterior maxillary teeth in a good relationship of symmetry between the right and left sides, inside an ellipse, as I showed earlier. The functional and the aesthetic results after the end of the surgical orthodontic treatment and the aesthetic improvement with composite resin veneers. The extraction of the lower premolars allowed the second molars to remain in occlusion, since the perimeter of the lower arch was compatible with the perimeter of the upper arch. The final results of the face and the lateral head film showing the final good relationship between the incisors. An important observation regarding to final soft tissue aesthetics of UCLP patients is that even after orthognatic surgery, the relationship between the upper and lower lips will not be as good as that of patients without cleft, or with cleft without lip involvement, as can be seen in the results of these patients on the right side. In this another excellent article published by Korean colleagues in 2015, they show the aesthetic limitation observed in class 3 cleft patients rehabilitated with orthognatic surgery compared to class 3 patients without cleft, also rehabilitated with orthognatic surgery. In cleft patients, the final aesthetic results is impaired by the remaining deformity in the lower lip. Finally, I bought this article published in 2019, which shows us the degree of satisfaction obtained with orthognatic surgery in cleft patients. And you see that the aesthetic complaint regarding to the nose and the lips remains in cleft patients at all stages of treatment. The authors, therefore, recommend adjunctive cosmetic surgery for nose and lip in cleft patients after completion of orthodontic surgical treatment. Thank you so much for everyone's attention. Goodbye.